I'm Corrado Tamburino, full professor of cardiology at Catania University, Italy, director of cardiovascular unit at Policlinico Hospital and San Marco Hospital in Catania University as well. The SCOPE2 trial aims to compare two self-expanding valves, as done in the past with the coronary stents. When a new stent comes into the market, the first objective is compare it to the historical stents that we know very well already because used in a lot of patients. And so we do randomized studies head to head. In this case, we are comparing, and we compared two self-expanding valve head-to-head to see if they are similar or not. And the study was a non-inferiority study. And the scope, the aim of the SCOPE2 was to see if there were differences in terms of death or stroke at 1 year and new permanent pacemaker at 30 days. The first two events were used for assessing the non-inferiority, whilst the second, the new permanent pacemaker implantation at 30 days, was tested for superiority. So the design of the study was a one-to-one study randomization, 796 patients, 50% allocated in the Evolut and the 50% in the accurate neo, and it was a one-to-one. And the primary endpoint, as I said, was all-cause of mortality or stroke at 1 year, and the key secondary endpoint was the permanent pacemaker implantation at 30 days. And there are some other secondary endpoints that are the components of the primary endpoint, some procedural complication, the safety endpoints, so clinical safety endpoints, finally the composite endpoints defined as VAC2, and finally the valve performance by echocardiography assessment. So my key results are, I would say, disappointing because it was unexpected, but this is my personal opinion. So the death or stroke occurred in the accurate neo in 15.8% of the patients, and in the core valve Evolut in 13.9%. So with an absolute difference by 1.83%. The upper confidence interval was set at 6% for being the accurate neo non-inferior, and the upper confidence interval crossed the non-inferiority margin, so was 6.12. This in the intention to treat analysis. If we go to the per protocol analysis, the upper confidence interval was below 6%, it was 5.42%, but due to the fact that per protocol, the two type of population, intention to treat a per protocol analysis, they must be non-inferior, both of them. The study didn't show the non-inferiority of the valve, the accurate neo, as compared to the core valve Evolut. There are some other points. The pacemaker implantation difference was 7.5%. So we would say that the accurate neo is superior in terms of pacemaker implantation. Moving to the secondary endpoints, we have some 3 points to discuss. First, overall mortality is the same, no difference. Cardiac mortality is higher in the accurate neo, both at the intention to treat and the per protocol analysis. New pacemaker implantation is better in the accurate neo, which is superior, both in the intention to treat the per protocol analysis, and new left bundle branch block was superior in the intention to treat in the accurate neo as compared with the accurate, so better as compared to the core valve, so better the accurate, but this advantage disappeared in the per protocol analysis. So at the end, we can also add the data of a paravalvular leak, which I think is responsible for some events. So the leakage are clearly superior in the accurate neo. This is related to the lower radial force of the accurate neo. We have 9.6% of a moderate to severe aortic regurgitation at 30 days versus 2.9 in the core valve. And at 1 year, the difference is diminished, is 4% at 3.3%. But by the way, there is a significant better outcome in terms of aortic regurgitation in the core valve evolute when compared to the accurate neo, either at 30 days or 1 year. So both analyses were positive for the core valve evolute. What we did is we dive in the analysis patient by patient for the cause of the reason of mortality. And we observed that most of the patients, almost all the patients who died for sudden death of decompensation, cardiac decompensation or heart failure. So there is, and all these patients had mild aortic regurgitation. So the link between aortic regurgitation and death seems to be very strong, has to be demonstrated with solid data. We don't have that enough to state that this is true, but this hypothesis generating. The only explanation we have, we can demonstrate is this. The conclusion is that this first generation of accurate neo needs to be iterated, and this is the scope 2, the Gen 2 of the accurate neo provide a good iteration of the first model because there is an external skirt that reduces the paravalvular leakage that are responsible for aortic regurgitation that may be linked to the cardiac mortality. This is the first point. Second, we know that when we want to reduce the pacemaker implantation, we want implant. We don't want a pacemaker. Accurate neo is a good valve to be used as compared with the other self-expanding valve in supraannular position. Third point, also the new left bundle branch block is reduced with this valve. So if we pay a lot of attention in implanting the valve with an accurate post-dilatation and reducing the paravalvular leakage, this valve could be a valve useful in some niche of patients. The take-home message is that at the moment, the accurate neo has to be iterated, and there is a link between cardiac mortality and probably aortic regurgitation. So we should pay attention to this specific point. Is needed a research with the novel model of this valve where the external skirt, as I said before, provides a sealing, a most perfect sealing, and so meaning that there will be not so many aortic regurgitation linked to the paravalvular leakage, and so the performance of the valve will be improved. So has to be demonstrated, and this is what should be done.